Good evening and welcome to the first webinar in this series, Motherhood and Mental Health. My name is Richard Lundy. I am the Program Director of Sikunye and I will be your host tonight. And we are so glad to have you with us in this series. If this is the first time you have heard of Sikunye, we are an initiative of Common Good, a not-for-profit organization founded in 2005. It aims at seeing people flourishing at three key periods in their life. Firstly, in their first 1,000 days. Secondly, while they are receiving primary and secondary education. And thirdly, when they are seeking employment. Now, Sikunye connects two things, the first 1,000 days and the local church. The first 1,000 days, from conception to the age of 2 years, is an extremely important period in a child's life, where their brain is developing faster than at any other time. In fact, the brain grows to 80% of its adult size by the age of 2. And baby's brain is really sensitive to what is happening around him or her. And if the young child consistently gets enough of what they need during this time, their brain forms strong foundations that allows them to learn well and to flourish into childhood and into adulthood. On the other side, if the child does not receive enough of the right type of care, the brain does not get that good, strong foundation, and they can grow up only surviving and not thriving. And they face additional challenges across the life course. The first 1,000 days is a never to be repeated time of brain development, and we need to be paying attention to it. And Sikunye's specific focus is on equipping local church communities to provide support to parents and caregivers who have children in this important stage. We all know that parenting is hard, but when parents are in loving, caring, and supportive relationships, they can better provide what baby needs to reach his or her full potential. And we believe that local churches and faith communities are well positioned to do this. And we have a range of training and workshops to bring awareness and equip churches to play their unique role. We don't look to churches to do everything. Instead, we look at them playing their part in a whole of society approach to seeing young children get a strong start to life. Now that I've introduced Sikunye, please feel free to introduce yourselves. Use the chat box to share your name and perhaps what organization or church you're representing. One of our intended outcomes is that you get to meet people and connect with them outside of this series. Please note when you are using the chat box that you have two choices of who to send messages to. The one is to the panelists and hosts or the speakers for tonight, and the other is to everyone in this webinar. Now, the question is, why are we as Sikunye holding a three-part series on maternal mental health? We want all children to get a strong start to life. We want them to reach their full potential, and we want parents and caregivers to flourish too. The future we want for our nation will be heavily shaped by the care that young children receive. And perinatal mental disorders can negatively impact parents and their ability to be the parents that they want to be. And you will discover in tonight's session the impact that mental health challenges have on families and how many families in our nation are facing this. And remembering behind these numbers are families, are stories of real struggles and suffering. And we want there to be a new story in our nation. We are not content to leave things the way they are. But why are we talking about the local church and their role? Well, the church has the potential to create spaces where moms and families experiencing common perinatal mental disorders, they can find a safe and supportive community. The church has the potential to have families where people listen, that they truly care, that they're not facing it alone, where they have people who can walk with them through the valley. And the challenge is, and we're going to explore this a little bit more next week, is that not all moms with common perinatal mental disorders experience support in their church. Sometimes they can feel isolated, judged, and even blamed for what they're experiencing. Sometimes they don't feel like they can talk about mental health struggles, and there's misunderstanding and shame and withdrawal from community. So to see churches be that kind of supportive place, we have to pay attention to what moms and families are experiencing. And we're going to talk about it here and over the coming weeks, and we're going to explore ways in which we can all be part of the community of support and care around families. Now, we are hosting a range of speakers from different disciplines to help us unpack this topic. And this diversity can help us all approach this perhaps from a new angle. And let me share a brief disclaimer here. In this three-part series, each week has a different theme or topic. And so some sessions might feel like we're featuring more of one kind of voice than another. And so we encourage you to view the whole series and engage with all speakers. And so you attending today also are from different backgrounds and have varying expectations. We had over 300 people register for the event tonight from over 12 different countries. And you are here maybe from a non-profit organization, government department, academic institution, a local church or faith community, or you're a concerned citizen about this big topic. And because you are coming from different perspectives, you might hear things that you 100% agree with, some things that you might have difficulty with, some things that might offend you, some things that you might need to explore further. You might be encouraged by some things and challenged by others. And I trust that we can learn with each other and from each other. And these two big topics about the church and mental health, let's lean into that for a second. Each of you will have experiences and stories to tell about church. These might be positive stories, negative stories, or a mixture of both. And when we're talking about mental health, we also have various experiences, maybe our own or perhaps of someone close to us. And both of these topics can bring up a lot of emotions for us. And so for everybody that is here from all these various backgrounds, I want to say welcome to each and every one of you. For South Africa and the communities in which we live in to have a brighter future, we need a whole of society approach to the first 1,000 days. And Sikunye's goal is just one slice of that, to see churches play their part in seeing children reach their full potential. Our hope for tonight and across this series is that we are all freshly motivated to look out for families experiencing maternal mental health challenges, that we are better informed and create spaces to have more conversations and even take steps in how we can play our part in providing the support that the families need. Now, along the line with that message, I want to underline or highlight something really important. If you've been in other Sikunye message webinars, you will have heard us say this, that all families need some kind of support to provide what their young child needs to thrive. Pregnancy, birth, and parenting brings big changes to every mother and father and family, whatever they look like. But as we focus in on this topic of maternal mental health challenges, it might be easy to reach the conclusion that only moms experiencing these things need support. But that's not what we're saying. Again, I'm going to say it. All families need some kind of support. And some families need all the support that they can get. Moms experiencing, for example, postnatal anxiety and depression, they need more support. But that does not mean that other moms don't need support at all. So I'll say it again, a third time. All families need some kind of support, and some families need all the support they can get. And in this series, we're focusing in on those who need that more support or all the support they can get. And to find out more about how you can be part of the village of care for families in general, you're invited to join other Sikunye webinars on this topic, and I'll tell you about them at the end of the session tonight. I know you've been paying attention to what I'm saying, and you've heard me use a few phrases to describe mental health already. And this is part of the complexity of talking about this topic. Some of these words or phrases I know you've heard, some might be unfamiliar. So I wanted to share some of these phrases that you are going to hear the speakers use and hear me use so that we can all be on the same page and perhaps avoid any confusion. First of all, we're looking at the time around when baby is born and perhaps a little while earlier. And to describe this period of time, some people use the words prenatal or antenatal, describing the time before birth or pregnancy. Postnatal, meaning after baby is born. Some people use the term perinatal, which describes the time around when baby is born, just before and just after. And some people use the word or term postpartum, which is talking about the period after baby is born. And so it is during this period that we're going to look at maternal mental health. Or another term that we use is well-being, right? But what does well-being mean? At its simplest level, it's to be well. Let's talk about physical well-being for a moment. I think everybody on this call has experienced the time of being physically unwell. We've had a cold, a stomach bug, and so on. And we might go to the doctor or we describe to somebody else what we're feeling. Those things that people can't see. And sometimes what we're describing are minor things, and other times that can be quite severe. Maybe you needed medicine, maybe you returned to full health without medical intervention. In certain cases, you might have gone to the clinic or the hospital to get the care that you needed. And so when we're talking about mental health and well-being, I think we might be able to use similar language. And again, I think all of us have been in a place where we are not doing well emotionally or mentally. We've been struggling. We don't feel like ourselves, and it's affecting our lives. Maybe it's affecting our sleep, our energy levels, maybe how quickly we get angry, and so on. And it's similar to when you're doing unwell physically. Maybe these things are minor, but maybe they are severe. And sometimes you might return to mental well-being without help from others. But for some, additional care and support is needed, and perhaps medicine or hospital care. And so some of the terms you might hear used tonight include mental illness, mental disorders, and mental health conditions. And these are different phrases that are trying to describe a cluster of things about what mom is experiencing. Now, this series is all about focusing on what mom might be experiencing as mental and emotional unwellness during the time before and after baby is born. And this isn't always easy for others to see what is going on inside of mom. And so people can overlook her. During the time that baby is born, there is so much going on. There's so much change and disruption that the symptoms of mental health challenges perhaps are overlooked or maybe explained away, and the appropriate care is not offered or taken up. And so tonight, the session is all about the issues of this topic of maternal mental health. We will explore the signs or symptoms with Dr. Nikki Dawson. We'll unpack the statistics and how these issues impact mom and baby and family with the Perinatal Mental Health Project. That's Dr. Estelle Fenter and Associate Professor Simone Honigman. We'll also explore the themes of who is responsible for addressing these challenges with Linus Muvu from SPANS in Zimbabwe. We are recording this session and distributing the presentations and slides via email. So look out in your inbox tomorrow for what will be shared tonight. An invitation to use the Q&A tool on Zoom, the little Q&A box at the bottom to ask questions of the panelists. They may be answered in writing or may be answered live by speaking. But you can also use the chat box to be able to answer your questions if you're not able to use the Q&A box. Now, one last thing, a couple of disclaimers before we introduce our first speaker. This topic might bring up big emotions and big feelings inside of us, maybe because of personal experience or the experience of people close to us. You might find this webinar series difficult, and I want to recognize and acknowledge that. The nature of this kind of platform is that I can't see what is happening in your space. I can't tell what you're experiencing. And it's difficult or even impossible to hold the space of your emotion and perhaps pain on this kind of platform like Zoom. And so I recognize that it might at times feel like I'm overlooking that or moving into the facts and not acknowledging your experience. And if you are feeling that way tonight or in the coming series, I invite you to speak to someone after the session. Practice good self-care and to be kind to yourself. Also have to share that this is not the kind of place to be sharing personal stories. You might have a question for the panelists that's relating to your own experience, or perhaps that of someone who's a close family member or friend. Our speakers will not be able to give professional advice on a personal case-by-case basis, not on this kind of event. We simply can't create a safe place or a safe or appropriate environment on Zoom for them to answer it appropriately. And so I encourage you and invite you, if you have that kind of question that's very personal, to seek out the services of someone in your community who will be able to give the time and attention that it deserves. In this series, if it feels too heavy for you to even attend, if it's too hard to participate, I encourage you to speak to a loved one. I encourage you to seek out the services of someone who can be supporting you. In week 3, we'll be sharing a range of resources and services and organizations that may be of help to you as you process what you're thinking and what you're feeling. You're most welcome to access them on the webpage that we'll be setting up after session 3. With that introduction done, I want to introduce our first speaker. Dr. Nikki Dawson is a counseling psychologist and researcher at the Ububele Educational and Psychotherapy Trust. She completed her PhD and master's degree in counseling psychology at the University of the Witwatersrand. And Nikki has worked at Ububele for 15 years, delivering and supervising clinical parent and infant mental health services for caregivers and infants living in Alexandra Township in Gauteng. Now, there are over 2,000 families reached a year through these services. Nikki also holds an honorary lectureship position at the University of Stellenbosch and runs a part-time private practice in Johannesburg. Nikki has a special interest in culturally and contextually relevant practice. I can't think of anybody better to ask the question and help us understand, Dr. Dawson, what are the signs and what are the symptoms of these common perinatal mental disorders? Over to you, Nikki.
Thanks. Okay, hi everyone. It's really great to be with you today. As Richard has already shared, I work at an organization called Ububele, and I'm going to be really drawing, I think, on our experience, the experience of our team over the last 20 years working with, as Richard was saying, 2,000 families a year in our talk today. I think importantly to say, this is not a training in mental health diagnostics, and it's not a training kind of for healthcare professionals. But as Richard has already said, there is such an important role that church communities and communities can play in supporting families. And so the way I've really kind of pitched this today is really thinking more about kind of what this might look like to a friend or a fellow church member if a family is really struggling with a perinatal mental health illness. So it's a somewhat difficult task to really share with you today about the signs and symptoms. And one of the reasons for that is because they aren't always obvious. And people might have seen this meme or a similar meme that goes around on the internet. Often perinatal mental health illnesses are related to mood disorders. They are around kind of people struggling socially and emotionally, and they're around struggling kind of with certain thoughts and feelings. And that's such an internal experience often, right? And often our internal experiences don't mirror what we show to the world and what is on the outside that people are experiencing and seeing. And this very common meme, I think, of Robin Williams, used really, I think, as an example of someone who looked on the outside to be really full of joy, was really struggling with depression for many years. The other reason why this is a tricky task, and why I think clinicians spend a lot of time developing these skills of really identifying and diagnosing mental illness, is because a lot of the experiences related to mental illness in the perinatal period or in the postpartum period are very common experiences that many new moms or many new parents will have. So, I'm sure if I asked you to kind of put up your hands if you were a parent at some point in your life, if you became a mom or a dad to an infant at some point in your life, and I asked you if you felt a reduction in your energy levels, or you felt extremely tired, or you found yourself much more irritable, or you found your body being in a lot of pain, or you found yourself losing interest in the things that you were interested in before you had a child, you'd probably put your hand up for all of these things. And so a lot of the signs and symptoms of perinatal mental illness can be things that are I guess, understood to be quite common, ordinary experiences of the very stressful transition often to parenthood. And as Richard was saying, this can, I think, sometimes be why they get overlooked or dismissed at times. So what can help us really as church communities or as communities surrounding families to kind of really understand who might be vulnerable um, to mental illness and who might need more support, need all of that support, as much of that support as they can get, as Richard was saying. I think the first useful kind of helpful signs for us are around risk. So we know that social support, or particularly a lack of social support, both very practical kind of social support, so someone to just really help you with, yeah, household chores and managing and navigating the day-to-day kind of increased load of parenting, can place families and mothers at risk for postpartum mental illness. As well as a lack of a kind of emotional support system and the lack of connection and people to interact with and engage with. And often in having a baby, people's isolation levels can increase actually, and so their social systems, their social support systems can become much smaller. And we know that this can really place families at risk. Also, we know that families where parents have had previous mental health difficulties are more at risk for mental health difficulties in the perinatal period. And so these are perhaps families or moms that we really want to be thinking about providing all the support, or as much of the support as possible for. And we know also that histories of abuse and trauma, as well as unwanted pregnancies, can place families at greater risk for perinatal mental health illness. Another thing that mental health professionals are often looking for is the duration and the kind of persistence of symptoms. So as we were saying earlier, fluctuations in our sleep patterns and in our ways of eating, changes in our mood, becoming more irritable, things like that are very common. But if they're very persistent, particularly kind of if they're lasting more than a couple of weeks, if they're lasting for months, these are families that we would be worried about. Another thing that's really helpful, I think, for our social networks and our communities to use as a gauge for who is really in need of more support. Some signs, I think, related to perinatal mental illness can really be around the impact of changes in mood, changes in sleep patterns, changes in appetite, changes in kind of emotional well-being, and how that's affecting and impacting on their life. So something we might look at is kind of comments from people around an impact on their work functioning, for example. So what this might look like, I guess, to a fellow community member or somebody, someone talking to someone in their church, they might be really sharing that they've not been getting along with their colleagues lately to the point that it's causing kind of conflict at work, and maybe even resulting in a disciplinary hearing or something like that. That might be a little kind of flag to us that the irritability is kind of mood fluctuations, mood changes are impacting on their daily life. And similarly, if they shared something like that around relationships with their child or with their partner, with their family members. Anytime we have any sense that there's a concern around kind of mood or memory or thinking or social interaction that's resulting in safety issues, we would be very worried. Right? So if somebody's forgetting their baby in the house, for example, or intentionally leaving their baby unattended in the house because they are so stressed, anytime there's a safety issue impact, we'd be very worried about a mental health illness. But also people's own personal experience, right? So if they personally are feeling overly distressed by the change and transition into parenthood and they're experiencing the lack of sleep, the impact on their mood, the impact on their relationships as very distressing themselves, that's really important. So we need to take that seriously. So what I want to do is just talk a little bit about some of the kind of signs and symptoms that we might that one might be taught, I guess, in a kind of mental health training, but really kind of I've tried to create real examples from Ububele's experience talking to and spending time with families that might mirror conversations you might have with families in your organizations or in your church communities that might help you kind of be alerted to somebody who might need additional support. So something I think that we experience quite frequently, or in mothers with postpartum depression, in the community that we work with, is we'll just be aware that there's a quite a blunted response to something really big that's happened in their life. So they'll be sharing with us perhaps that there's been infidelity in their family, or that there's been some kind of trauma in their life. But the way that they share it is quite blunt or quite affectless. So there's not a lot of emotion in the way that they're sharing it. You know, someone just saying kind of, it's fine, I accept it. That might be an example in some cases of someone whose mood is really low and whose mood is being impacted by mental health difficulties. Another common sign, a kind of common thing that we hear, I guess, quite a lot from parents struggling with perinatal mental health difficulties might be that they'll say that I don't talk to anyone, I don't want to talk to anyone, I don't have any friends, I'm not speaking to people that are really isolating themselves. I don't speak to my friends anymore. These would be things that should prick our ears up and really elicit a support reaction. I think a common phrase that we hear as well from parents is just, I've been thinking too much, and sometimes that can be an indication, a way that they're communicating that they're having distressing thoughts, you know, or have a more anxious kind of mood response. Something also that happens quite often is that we'll maybe come across families who are constantly consulting with healthcare professionals, and although healthcare professionals are reassuring them that their baby is okay or that they are okay, they will continue consulting. And we've worked with a few families, for example, who will maybe have an appointment with us. We'll connect them to maybe suggest they go and speak to the nurse at the clinic. And while waiting for that, they've gone to kind of speak to somebody else, and somebody else kind of really just not able to kind of stop worrying, and so constantly seeking out another opinion and another opinion. Something else, I guess, if we think about symptoms of mental health difficulties like forgetfulness or loss of interest, we'll have experiences with families where we'll learn that they've kind of abandoned their immunization dates for their infants, or forgetting about them and missing those appointments quite often. Or maybe in some of our HIV positive beneficiaries, where they've just missed their ARV collection dates and are no longer kind of attending to their clinic appointments, not because of resources or issues like that, but because it's kind of become really not top of mind anymore due to a mental health difficulty. Also kind of have worked with quite a number of families where moms have really shared things like they're really exhausted, but even though the baby's sleeping, they'll be kind of spending all night doom scrolling, and sometimes even just sharing that would kind of be a way that they're communicating. Actually, perhaps they might be having a lot of distressing thoughts, and so they cannot fall asleep, and they're preoccupying themselves through social media or something like that. And then also a common symptom of perinatal mental health difficulties might be moms who really have a low self-esteem, particularly in relation to their parenting skills. And this might come across through someone just sharing, I don't really know how to help my baby. I think I'm going to take her to my mother and leave her there. I think, sometimes moms will say things like, I'm sure the baby wishes that you were her mother rather than me. And these might be ways that families are communicating that they're really feeling not good enough about their own parenting. Again, of course, I guess quite an obvious sign at times will be if people are wanting to harm themselves or have suicidal thoughts. but people might not directly share this, but they might share this indirectly sometimes. They might say things kind of like, I nearly tripped and fell in the road yesterday, and I almost wish I had, or sometimes I think it would have been better if I had. So sometimes people's suicidal thoughts can be communicated in kind of these indirect ways as well. Something I did want to speak about, because it's a particular passion of mine and of Ububele's, is that sometimes babies can give us signs that their mother or their caregiver is struggling with postpartum mental health difficulties. And we might sometimes kind of, a sign for us might sometimes be, of something like irritability, which is a symptom of perinatal mental health difficulties. Might be that the caregiver is getting really angry or irritated at the baby in front of you for kind of small and very normal things. So sometimes, again, this is not necessarily doesn't necessarily mean that a mother has postpartum depression, for example, but it could be a sign to us that it might be worth activating some more support. Interestingly, and I guess importantly, we see often that in babies with mothers who are depressed, their moms won't look at their babies very much, or when they do, their faces are quite blunt and blank. And so what we see sometimes in those babies is they will stop looking at faces. And so this can be an indication at times that babies are struggling with the consequences of their mother's depression, and help alert us as well to a mother who is struggling, for example. And babies, importantly, can also become depressed, and can be really impacted, as Richard was saying, from a parent's mental health difficulties. So really noticing that they are struggling, and also, if a baby seems quite sad and doesn't really smile and laugh, that might also be a sign. I'm just mindful of time, so I'm just going to say two last quick things. And the first is that it is important, I think, for people to know that families can be at risk for quite serious mental health difficulties like postpartum psychosis. And so if you are ever kind of coming across a mother who doesn't know when it is, where she is, or who she is, we would really want to urgently to get to hospital, particularly well, always, but especially also if she's had a C-section, there could be quite a serious health risk happening for her. And just a couple last comments, because I know other speakers are going to really speak to this. But as I was saying earlier, support system difficulties are often kind of really at the center of mental health difficulties in the perinatal period. But importantly, they're also the solution. And so, a person, a family's community can really be such a big solution. And that's really, what we can do to help these families is really step in with practical support. Supporting exercise for mums is also a really helpful thing that we can just do. Just meeting up with mums to go for a walk in the park can be really, really helpful. Yeah. And a short message, I think, just that when we are calm and kind, and that is catchy for mothers, as well. So just really remembering that we can share our calm nervous systems to those around us. But I think I'm running over time already, so I'm going to stop there. Thank you so much.
Dr. Nikki Dawson, I want to thank you so much for painting this vivid picture for us. And what I have so appreciated about your presentation is how you bring together good science, those technical terms and thick textbooks that you learned at university and that you lecture in, and you're pairing it with the local context. What does it sound like when moms are experiencing this? You brought the context into the room, and I so appreciate that warning as well. We're not trying to label people. We're not trying to build a checklist and go, okay, you got three, now we're going to treat you like this. No, no, no. It's you're helping us understand to have compassion. To that final phrase that you said, to be calm and kind, is catchy. And you've helped us have eyes to see and ears to hear what to look out for, when we see those kind of things, to be moving towards families and not overlooking and just saying, ah, you'll get through it, you'll get over it, everyone goes through it, but actually to have that posture of kindness. And you also gave us a taste of what is coming up in session 3 about some of the practical things. I'm so glad you've done that. And again, thank you for your work at Uwabele and for sharing with us tonight. If anybody has a question for Dr. Nikki, please pop it into the chat box. She will be able to respond in writing in that Q&A function. Now, one of the challenges that we face with this topic is that we do want to hear from mothers and have their voices represented. At the same time, with some of those tables that Nikki just shared, we don't want to be exploiting women who put a spotlight on them when they are in such a vulnerable space. And so, in each of the 3 sessions, we're going to feature a video that has captured a story at some point in a mom's journey. Now, the first video is sharing the experience of a mother in Khayelitsha in Cape Town. And this is from the Perinatal Mental Health Project. And we're going to focus on just the first 6 minutes of the video. And in your email tomorrow, I'll send the link that you can watch the whole story. But you will discover through this series that there are many factors that are working to contribute towards maternal mental health challenges. And one of these factors is poverty. And this video unpacks some of these realities. Now, as with every video and every story, this isn't the story of every mother living in poverty, and not all women who experience perinatal mental challenges are living in poverty. This is one story among many, but it does help us understand and look out for some of the factors that are at work. So let's watch this 6-minute video together from the Perinatal Mental Health Project.
I didn't feel so happy. I know other people are happy about being pregnant, but I was not happy. I was sad. Not eating, not sleeping nicely. You are alone. When you're pregnant, you are alone. Everybody is talking like you did it to yourself. You don't have anybody when you're pregnant. Everybody just turn their backs on you.
We always see pregnancy as a happy event, but working in a maternity hospital and get to work with these patients, women that are in need, it made me realize that it's not always a happy event.
General population, we estimate about 16% of women have some form of mental health problem, depression, anxiety, and in pregnant women, it was estimated that as much as 35% have some form of depression or anxiety.
Putting depression is, but it must be like that, or it is just like that. It's the norm.
These women just sort of carry on, and people are not always aware of how antenatal and postnatal depression can manifest, or there's just not the knowledge that there is help out there and something can be done. And so people struggle on being depressed, which is really unfortunate because this has huge negative effects on the mom and the baby, and of course also impacts on the rest of the family.
A lot of women come from homes where there's lots of poverty, people are unemployed, there's abuse happening within their homes, there's the drug abuse, there's violence. They come from areas where there's lots of crime within the area, so they are always being intimidated.
Sometimes our patients, they leave their babies here in the hospital because of the problems that they are having at home. They couldn't share, or they didn't know where to go to share their problems.
Most of the women who are seen in the public health care service are women who live in extreme poverty. By US and European standards, these are women who are living well below the breadline, surviving on less than a couple of dollars per week. These are the women who are most likely to develop distress and depression during pregnancy and postnatally. These are the women who are also least able to actually access mental health services. For various reasons. Reasons that can be as simple as the fact that they don't have the transport money to get from one appointment to another. One of the most distressing things for pregnant women is to find out for the first time when they come to the antenatal clinic that they're HIV positive. It's for the first time that they realize that their partners were possibly unfaithful. So here they are, pregnant and having to deal with this devastating news that they have what to many people is seen as a disease that is going to kill them. They also have to deal with the fact that their unborn child is at risk. They have to deal with feelings of guilt around possibly passing this on. There's still tremendous stigma and discrimination against people who are HIV positive. Many women find themselves in the situation where they are blamed for this, where their partners immediately accuse them of being unfaithful.
We had a patient about 2 weeks ago. After receiving the questionnaire to fill in, it came to the fore that her husband was actually physically abusing her and had just beaten her the morning. And it was to such an extent that she had to be hospitalized.
Men are not working. Most of the time they're at home and they are frustrated. Then they end up hitting their women. Sometimes our patients come here and they say, we must check them if their baby is moving because they had a fight with a boyfriend at home.
Many of the pregnancies that we see, particularly in the public health service, are teenagers, adolescents who've now become pregnant. And in addition to all the other problems that pregnant women may face, adolescents face the fact that in most cases these are not wanted pregnancies. Very often there is no partner has vanished or there's very little partner support. They have to deal with disapproval from their families if their families know, or alternatively hiding pregnancies. Also because adolescents tend to indulge in more risky behavior, they've also got a high risk of being HIV positive. So there's a huge stress on teenagers who are pregnant, far more so than an adult woman who is pregnant.
I felt bad and then I felt guilty because I didn't plan the pregnancy. The worst part, I didn't plan it. And then I was angry to everyone. It is difficult because they don't understand you and they don't listen. The worst part, they don't listen. Didn't have friends at that time, just sitting alone. There is things that you can't talk with your family. There is things because they don't have that, the ear to listen. They don't listen.
This video is heavy, isn't it? It powerfully brings up the issues that many mothers experience. And one of the things that we say in Sikunye regularly is that every pregnancy story is unique. We can't put people into boxes and believe that everyone goes through the same thing. And this video reminds us to listen, to explore, to be curious about the various things that are going on in mom's life. The final line in that part of the video was mom saying, family does not have the ear to listen. They don't listen. And this is one of the stories that we want to change. We want mothers to have people to talk to without fear of judgment and without shame. And we'll be raising this more in week 2 and week 3 of this series, what practically can be done to be listening to families. As I mentioned, and as you saw in the video, this is from the Perinatal Mental Health Project that's based in Cape Town, where our 2 next speakers are from. Associate Professor Simone Honigman is a medical doctor with clinical experience in pediatrics, obstetrics, and gynecology and psychiatry. She has a master's degree in maternal and child health and is the founding director of Perinatal Mental Health Project that is based at the Centre for Public Mental Health at the University of Cape Town. She engages in advocacy strategies for maternal mental health for a wide range of audiences, and she consults to national and provincial health policy, guidelines, and program processes within South Africa and supports others' research, advocacy, and training work on the African continent and in other low and middle income settings. Dr. Estelle Fenter is a registered dietitian with a PhD in maternal and early life nutrition and long-term health outcomes. And together with Simone, she designs and conducts training for a wide range of providers and is involved in developing training content and other multimedia resources to support capacity building. And we've asked them to help us all understand the impact of maternal mental health conditions on the mother, on the child, and the family. And they will also be sharing the statistics and how widespread the issues are that we're talking about in the South African context. Again, a reminder that you can ask questions using the Q&A function or in the chat box. But over to Estelle and Simone.
Thank you, Richard. Let me get my screen up. Here we go. Okay, hi everyone. It's thank you for the opportunity to talk to you this evening on this important topic. And I want to start by saying if you've listened to Nikki's talk and you've identified some of these signs and symptoms in people you know, or perhaps you have experienced them yourself, unfortunately, we have to recognize that it is likely that you might know someone who has challenges with their mental health, or perhaps had yourself. Because it's estimated that about 1 billion people in the world live with a mental health condition. And while Richard very nicely in the introduction spoke about why the first 1,000 days is so important and the development of the baby, in this presentation, we want to talk a bit more about why exactly we at the Perinatal Mental Health Project focus on the perinatal period and why this is so important. So we're going to discuss the causes of maternal mental illness in the next session next week. But we wanted to briefly touch on some of the things that happen when a woman gets pregnant to just understand a little bit about where it might come from. So when a woman gets pregnant or goes through childbirth for the first time or becomes a parent, there are so many changes that happen in physical health. I'm sure Richard alluded to some of them as well in the beginning. So it may be physical growth, appearance, health status. You heard in the video about a lot of women learning that they are HIV positive. So there are many things that happens in a woman's physical body. And then we also know that there are so many changes happening in her broader life. It may be that she's concerned about how things might change in her education or in her job, her career plans that she had. There might be economic pressure. Relationships might change, her relationship with her partner, her relationship with her parents. You heard in the video about teenage pregnancies as well. So we're going to speak a bit more about that next week. And but I want to talk about all of these changes. Whether a change is positive or negative, change can create stress. And this will affect a person's mental well-being. So in the next session, we're going to talk a bit more about how all of these relate to each other and how they influence each other, because they're all interconnected. But because of all these changes, women are much more likely to develop a mental health problem around the time of having a baby than at any other time of their lives. And also we know that women who have already have a mental health condition, they might find that their symptoms are worsening during the perinatal period, or even if they had a previous, I think Nikki also mentioned, if there was a previous mental health problem, that it comes up again. So if we look at depression during pregnancy and the postnatal period, and we look at an high-income countries, we know that about 1 in 10 women have depression, and mental illness is one of the leading causes of maternal death in several high-income countries. And if we look at what happens in South Africa, we know that it's about 1 in 3 women that experience depression during pregnancy and the postnatal period. I'm going to repeat that. It's 1 in 3 women. And while we don't have a lot of good data and statistics about anxiety, a lot of studies show that it might actually be similar or higher rates. And something else I also want to highlight here is the problem is not only the amount of people or women who may experience mental health conditions or illnesses during the perinatal period, but there's a huge amount of people who do not receive the care or the support they need. So in South Africa, 75% of people with a mental health condition do not receive any care. And if we look at the more common mental health disorders, like your anxiety or mood disorders, your depression, about 90% of them do not receive any care. So I'm not talking here about medication or seeing a psychiatrist or psychologist necessarily. I'm talking about any care, any support. So we have firstly the problem that there are so many people who have who are experiencing mental health problems in this period, but also most of them are not receiving any support. And then we will be talking you through in the next few slides some more reasons why it's so important during this stage. Is it because it impacts the physical health outcomes of the mom and the baby, parenting, social and economic outcomes. It also impacts the whole family and the next generations. We also know that, fortunately, early support can improve outcomes. So that's why Sikunye organized this webinar, is for us to, the more people who can provide support in various ways, the better the outcomes are. So we would like to see that it is an opportunity for intervention as well. So if we look a bit about on the maternal outcomes, if a mother is experiencing depression or anxiety during pregnancy, there are lots of outcomes in her own health. So Nikki spoke about sleep or appetite problems. So it can either be too much sleep, too tired, or too little sleep. And the same with appetite, eating too much or wanting to eat the whole time, or not feeling like you want to eat anything. Then we also, there we go. We also look at the poor pregnancy outcomes. So when a mother experiences depression or anxiety during pregnancy, it does directly influence the pregnancy itself. For example, there might be poor weight gain, there's a higher risk of miscarriage, and there's also maybe poor birth outcomes in the infant. For example, preterm birth, low birth weight. There may be problems with bonding, and Simone will talk a bit more about that. The bonding is with the infant. And then it might also lead to self-medicating, either alcohol or any other substances. And the problem with that, it can become a vicious cycle where alcohol or substance abuse can also make mental health worse. Then maternal depression or anxiety during pregnancy can also increase the risk of domestic violence because of, and Simone will talk a bit more about the dynamics between mom and a partner or a father, and you saw in the video as well of the prevalence of domestic violence. And then also it may lead that, or may cause that a woman does not want to use health services. She may not feel that she is able to get out of the house. She doesn't feel up for it. So she won't go to the clinic for antenatal visits, and also postnatally, she may not take the baby to the clinic for health visits, immunizations. And I'm sure if you've attended any other of Sikunye's work, you know the importance of that. So it may lead to more infections or sickness in the infants. It may also lead to a loss of economic potential for the mother if she cannot do her job properly, or it may lead to less education or not being able to attend education. And then, unfortunately, it also increases the risk of maternal suicide. So in South Africa, it is estimated that about 1 in 10 women are at a high risk of suicide. Now, the good news is that this all may be prevented by early and good management. Like I mentioned in the previous slide, that is why we want to provide support as soon as possible. And then if we look at some of the outcomes in the child, so some of the impact that mental illnesses may have on the child or the baby. I've mentioned before low birth weight, preterm birth, or even stillbirth. There may be trouble breastfeeding, and I'm sure, again, if you follow Sikunye's work, you know the importance of breastfeeding, and not only the bonding that it, or the nutrients that it provides, but the bonding, the safety that it creates, the secure attachment that it creates with the mother. So if a mother is feeling depressed or anxiety, then she might have trouble breastfeeding. Spoke about bonding, and I think you've also saw in Nikki's slide, she spoke about, or one participant mentioned, the baby cries a lot. And there may be various reasons for this, and we obviously know there are a lot of physical reasons that can also cause crying, but one aspect is that it's possible if the mom is experiencing mental distress or a low mood, like Nikki said, she might not be able to respond quickly to the baby's cues. She might not be very attentive to the cues, and therefore it may lead to a crying baby. In severe cases, it can lead to abandonment, abuse, or neglect, being angry towards the baby. And a surprising outcome for a lot of people is that it may actually impact the child's mental health and behavior during childhood, but also later in life. So there's a lot of learning that takes place in the early years, and it may cause problems later in life. And the same with poor language and motor skills. If a mother is not able to provide, to be attentive, to provide stimulation, to provide that love and caring, secure environment for the baby, there may be delays in the baby's development of language, of motor skills, and so on. And we spoke about poor immunization and sickness in the previous slide. Now, what I want to stand still with before we move on is, although it may be, these outcomes may all be prevented or at least buffered to some extent if there is another well caregiver. But it is very important that we don't blame the mother for this, or we don't threaten her. And that we realize that it is not the mother's fault for feeling this way. I don't believe that there is one woman who would ever choose to deliberately harm her baby. So we need to take a step back and realize that there are so many wider things that may be contributing to why this mother is feeling like this, why she is experiencing this. And if we can find a way to support her and the wider family and the infant, then we are on the right track. But we cannot blame her. We cannot make her feel worse, because that is all that it will do. And then I want to lastly touch on the intergenerational cycle. So I spoke about this can become a vicious cycle, unfortunately, if a mother is ill and the care she provides to the infant, you saw all the various different outcomes in the child, then it can lead to problems or challenges in the child's mental health when they are older, when they become parents. So it can be a vicious cycle, but fortunately, we like to see it as a good opportunity to intervene, and that it can become a virtuous cycle as well, a golden opportunity. So with that, I would like to hand over to Simone.
Hello, everybody. It's a real privilege to be speaking with this wonderful group of people. Thank you, Estelle. I would like to speak a little bit about the relationship, because Estelle has been speaking about it's not just the mother's fault that we can have these negative outcomes. I think we need to look at the woman in context of the close people around her. And for some women, that's a partner. And for other women, it's a granny or a sister or somebody she's sharing, or her own mother she's sharing the house with. And it's important to realize that the mental well-being or the mental health status in all the people in the household interact and affect each other. So if we look at the classic relationship between the mother and the father of a child, we know that fathers are also at risk of depression, especially facing these same risk factors. The same could be said for grannies or the mother's mother in the home. If that person has also faced trauma and poverty and isolation and discrimination and all of these risk factors, that person too might be experiencing a mental health problem. And the change of the pregnancy and the birth and looking after a new child places additional strain on this unit. And so so all the people in the house might be feeling this and might be showing different signs of distress. Indeed, fathers can get depression just like mothers. It is less common, we think, although there's been a lot less work and research done on the mental well-being of fathers. But what we do know is that the mental well-being of the one person impacts the other and vice versa, or the mental distress in the one person impacts the other and vice versa. So if you, Estelle, if you can just go on. So if we know, and Nikki has been speaking about it, that the mother may be having a range of different symptoms. She may have a lot of worry preoccupying her mind about the baby or wellness. She may have worry about other things. She may have difficulty connecting or bonding with her baby or communicating with her baby. She might be feeling a lot of physical problems, which are not necessarily her putting it on or faking. She might really physically be experiencing more physical problems, because people with mental health conditions often do, and those physical problems are often ignored. And she may be having sleep problems too. So all of that is going to affect the relationship from her side. Those are typical ways in which a woman might be showing her symptoms. Then a man might be having a whole range of symptoms that might reflect a little bit differently, often because of gender norms, of how society expects men in distress to behave. So it might not be conscious, but men who are experiencing anxiety or depression might show this with anger, with irritability. They might avoid the home, they might avoid the woman or the baby, they may avoid their responsibilities, they may be isolating themselves, or they might make decisions or do things impulsively. And you can see how those symptoms in that person can affect the mother and vice versa. Okay, now let's go out and take a wider look. So we have these two parents whose mental state is affecting each other. But they don't exist on their own either. And I think I'm seeing this in the chat from some of the comments that have been made, that these people, as we know, and especially in an African setting, exist within a wider setting. And many parents are carrying not only the stresses and hurts of the current situation, but they're carrying this from their past and their past traumas, and they don't have the space or the language to name them. So what's happening outside of the household? Well, we know within the house itself, there might be other people in the home. I see in the chat people are speaking about siblings. We know that often many generations are in the home, grandparents. What is the well-being, the mental health status of those people? How is it affecting the mother and the child? Beyond the home, we're looking at the community, the church. We're looking at the healthcare system. All of these systems interact with the family, with the father and the mother, or the mother and the other caregiver of the child, and can act to be quite negative. So there can be disapproval, there can be additional stress, additional emotional pain, there can be conflict, there can be unhealthy silences or avoidance from all of these people in the wider ecosystem. But on the other hand, as Estelle said, these are all different sources of powerful support that can make a big difference in the mental well-being of this family. So these entities, these organizations, these communities can have a role in terms of safety, in terms of help, in terms of practical help, in terms of emotional help or spiritual help. This is going to be discussed in a future session, but it's important to realize that when parents are supported with compassion and understanding and community care, healing and healthy development can become more possible, because in the middle of this relationship we have this infant. And this infant, as we know, cannot be raised by individuals, but needs ideally to be raised by this village. And this village includes all of these players. Okay. Thanks, Estelle. If you could just move on. So what does this mean? It means, in summary, that mental health conditions in the parent impact the child. Mental health conditions and strain in the community will impact the child. These mental health conditions, if not treated well, can lead to poor parenting behaviors, less parental warmth, fewer healthy interactions, which are so essential to feed the developing brain, and poor quality of relationships with infants, and then later with children. As Estelle mentioned, these can lead to long-term problems, not just at the time of the mental health problem in the parent, but long-term. This can affect the brain and can affect the whole way in which the child goes out into the world. And we look forward to sharing the good news with you about all the things that people can do. One doesn't only have to rely on psychologists and psychiatrists. There are very, very important roles that a church community and a lay community can play in supporting women and families. Thank you very much. We look forward to looking at some of your questions.
Thank you, Simon. I had a look at the chat, and I see there are quite a lot of questions or comments specifically about I think what we're going to be talking a bit more in the next session about the causes, all the various things that contribute to poor mental health in both the mother and the father, and others in the community as well. So if your question related to that, please know that please join us next week, and we'll get to that. And then there's a question in the Q&A that we would like to answer as well. So I'm going to read the question quickly. It says, if a mother is always emotional and does not eat properly, she comes not to take the baby for immunization. She does not want company and help. She is suicidal. What can we give her? Simone, do you want to take that?
Sure. Thank you for that question. I think the person posing that question is noticing a lot of things and noticing how certain behaviors in the woman and certain physical features are clustering together with emotional features. And I think that's really, really great that you've picked that up. We need to be concerned about suicidality, people who want to harm themselves, absolutely. And it's quite a scary thing to have to manage as a non-health worker. Even for health workers, I know it's very scary to manage when somebody's speaking about harming themselves. I think it's important that if you pick up that that problem, that you stay with the person. Your presence and simply being with that person is a powerful way of ensuring safety. You don't have to do much else other than be with that person with kindness, with calmness, with compassion. That is gold, absolute gold. And if you can take that person to be assessed, all casualties have medical officers who are trained to assess for suicidality. And how severe are these feelings of self-harm? How long has the person been having it? Does the person have a plan to harm themselves? Or is it just a thought and it's just a sign of distress? Has the person had a history of harming themselves, which makes us more anxious and more concerned for their safety? So we look at all these things when it comes to suicidal thoughts to assess, do we need to keep them in a safe medical environment until we can get them better? Or can we have a discussion with them and send them home with a supportive person to be with them to ensure their safety so that they can come in as outpatients for help? I'm not too sure if that's a helpful answer.
Thanks, Simone. Something I want to just add to that answer, something we haven't really spoken about yet is, I know it will come up in the next sessions, but a bit about, we spoke now about more the common mental illnesses, depression and anxiety, but we are also aware that there are other conditions that are much more severe, like psychosis, schizophrenia. But what I want to highlight is, even if a person is suicidal, or if a person is experiencing depression or anxiety, it does not mean that that person doesn't know what is best for them, or that they don't have any agency, or they don't know what's good for them. They may be struggling, but we still need to try and evaluate where how much agency we can give that person, how much support we can give that person, and where it becomes necessary to intervene more directly in order to keep them safe and people around them, especially if there is a baby that they are looking after as well. So yeah, there is a bit of intuition, a bit of can't get the word now, but a bit of assessment that or evaluation that one would need to do. But if it is serious, then I encourage you to get help as soon as possible. We will also share. We have a directory, resource directory that we will share that has some helplines that you can use if necessary. Okay, I think all the other questions or that I'm seeing relates a bit more to our talk our session for next week. So unless there are any other questions on what we spoke about today, the impact of on the mother, on the child, on the wider community, then yeah, Simone.
I'd just like to comment. Do we have time, Richard, just to comment on?
Yes, go for it.
There is one comment here in the chat about, I think it's about, it might be about adolescents or people who get pregnant because they think they're going to survive with a child support grant. That is a common myth that people believe in South Africa, that the child support grant makes women get pregnant and especially makes teenagers get pregnant. But in fact, some of our colleagues at the University of Cape Town, the Children's Institute and others went and did the research on why people on this thing that people believe that people get pregnant because of the child support grant. And in fact, it's not really true. And since the beginning of the child support grant, there has not been an increase in teenage pregnancies related to the child support grant. So we know that the support grant is very important for the survival and for the nutrition and for children to get into schools. It's caused those really, really positive results. But it certainly isn't an incentive for people to get pregnant. There was a very careful research into this. And I think we need to just make sure that we continue to push our government to provide financial support for people who don't have enough, so that they can survive and they can thrive. And it's a duty, I think, that we have ethically as a country to look after the poor.
Wonderful, Simone. Thank you so much for addressing that. In fact, a couple of years ago, we had a webinar series very similar to this in Nature, exploring that topic of teen pregnancy and the local church, and explored that very research that you mentioned and the impact that it has, the positive impact that the child support grant has on the teenagers' outcomes. But I want to thank Estelle and Simone for your expertise that you've shared with us. You've painted such a vivid picture for us. And a couple of the standout points that I want to just highlight for us in summary is that it's more likely that mom will have mental health challenges around the time of giving birth. And that what we're looking at, these are big issues, not limited to what's inside mom's mind, but impact on other parts of her life and her body and her relationships and her community. And a key message, if we could highlight your computer screen, your phone, and saying, don't blame mom. This is not her fault. And especially next week, we'll be unpacking that a little bit more. It's so easy to blame someone for what they're going through. And you've called us very kindly and very bravely to say, don't blame mom. You've also helped us see mom and dad are in a context of different relationships in their household and in their community. And so part of this purpose of this series is that we're able to have conversations that you might notice a loved one who is struggling, that you're not walking with them alone, that there are other organizations and even other communities that can be part of supporting moms. We delved into some very heavy topics in your presentation, and I want to make sure everyone here feels like they can reach out to somebody else to ask them for help, whether it's that helpline, a website, an organization, to find out how you can best serve mom in the struggles that she's facing. Now, these issues are affecting a large number of families, 1 in 3 even for postnatal depression. And it raises the issue, understandably, and it even came up in the previous presentation, is, well, whose problem is this? Or maybe phrased differently, who needs to address this? Who can we turn to in order to reach and support mothers who are facing these big challenges? And our next speaker has a powerful story of doing something about it in his home country of Zimbabwe. Rather than waiting for someone else to step in, he did something. Linos Muvu is a keynote speaker, a global advocate for perinatal, paternal, and child mental health. His interest in perinatal mental health spans over 16 years, and he founded the Society for Pre- and Postnatal Services, abbreviated as SPANS, to help ensure that all parents and families are supported throughout the life cycle using a family-based approach. He also founded the International Conference on Maternal Mental Health in Africa and the Society for Pre- and Postnatal Services Vocational Training Institute to close the gap in the shortages of mental health professionals in his country. He's also the African ambassador of International Fathers Mental Health Day, and working alongside other academics, local newspapers, and radio programs, Linos has written many abstracts, several stories, papers, and articles. In our preparation for the webinar, we recognized that a stable data connection was unfortunately not possible, and so we have a recording of you tonight. And even in recording this, we had some technology challenges and had to switch platforms to bring his message for you tonight. He is on the call and will be able to answer any questions via text in the chat box if you have any questions for him. But the question we wanted him to speak into is to ask the question, with the issues of maternal mental health being so big and so widespread, who is responsible to address it? Whose problem is it? So let's watch this 10-minute video together exploring whose problem is this big issue.
I just want to greet you all and say, it is my pleasure being invited to be part of this webinar, which is very important. It speaks to what I believe. It also speaks to my passion. I am Linos Muvu. I'm based in Zimbabwe. I'm an advocate for perinatal, paternal, and child mental health for almost 16 years now. And I'm the founder for the Society for Pre- and Postnatal Services in Zimbabwe, pioneering project around perinatal mental health. So today, as I was invited to be part of this webinar or series, my task is very simple. Most people, they wonder or they ask themselves, when it comes to perinatal mental health, are they part of the problem or not? So I'm here to clearly answer this question by saying, within the African society, there's a very good saying, which we all know, that it takes a village to raise a child. It also takes a village, to look after, a mother who is pregnant. So in other ways, what I'm trying to say is, it takes the whole system or the whole family, to make sure that, during pregnancy, we need, the husband or the partner to be there. We need the mothers, both in law or, the mother, where the wife she's coming from. We also need the society, if the society, it comprises, or the environment, if I can say, it comprises of the people from the church, it comprises friends, it comprises, other significant others who are also part and parcel of the mother. So in other words, we are saying when we want to address perinatal mental health issues, we need to take in consideration that, the church plays a big role, the parents, plays a big role, the partner plays a big role to make sure that, the future of the child, which the unborn child, which is very important, was like, it's very simple. What is the mother? That's what they are saying. If the mother eats, whatever she eats, it goes direct to the child. The same applies. What the mother feels, it also affects the child. So if we need a child who is mentally sound, we need to start from, supporting the mother during, the first environment, which is the utero. So just to say, we are not just saying things, but also to give a very good and a clear example that, as I mentioned, that I'm working in society for pre and postnatal services, and we are pioneering perinatal mental health project. Since 2010, when we started this organization, we managed to introduce some very interesting initiatives or successful stories that I can share. In 2016, we managed to become the first organization in Africa to initiate an international conference on maternal mental health in Africa. Just to look at, to bring people or stakeholders together to convey and talk about this very important topic. It is not a secret, even from the WHO perspective, that we have a huge shortage globally, of the mental health care workforce. So as an organization in 2019, with the support from our Ministry of Health and Child Care, we introduced our level 5 diploma where we are training family therapists, and these family therapists, they're on the allied health care of Zimbabwe, practitioners of Zimbabwe register. So up to date, we managed to attach more than 300 family therapists to different, healthcare facilities in Zimbabwe, and we had 3 graduations so far. And this year, we are going for the 4th graduation of this family therapist, in an effort to make sure that we don't just wait for severe chronic mental health issues, but also to like the mental health temperature. When somebody goes to the clinic, they screen for a BP, for BP, for and other issues that they screen. We need also to do that at primary health care, especially to mental health. When people are screened, and when we do screening, we need also to make sure that there's therapy. We screen for this mild, moderate, and even expressions. Like into our context, people, they express their mental health issues more than waiting for these medical terms. So as an organization, we are focusing on having that card at community level, do the screening and provide family therapy, where they bring the whole family to the table to discuss issues that they affected them. So that's where we are as an organization. That's why we are saying it takes a village to raise a child. That's why we're saying it's a whole, system, or the whole family, things when we approach perinatal, mental health issues. So I just want to take this opportunity to thank you, and I want you to join other colleagues during this webinar series. I thank you. Language barrier was a very important topic. It was a very big challenge. When talk of mental health, people, they know how to express themselves, so that becomes a problem. And also, cultural issues. Those were some of the challenges that we face. Different cultures, they've got different beliefs when you talk about mental health issues. Yes, some funding, to reach out now to the community. That was another challenge that we faced. We also faced the huge shortage of mental health practitioners. Yes, as much as we want to, we advocate, we educate, but people, they want service. So that's another challenge that we faced, and we are also working on infrastructure itself. Counseling is a confidential thing, so there's need for that infrastructure, where people, they can sit and in a secret, in a private. So we want also to make sure that it is improved. So that was as a challenge as we reach out to communities to try and advocate for perinatal mental health. Thank you so much for raising that question, Richard. Perinatal mental health is very, very important, and I want everyone to invest in. Why? Because what is the mother affects the child, and also what feels the mother affects the child. And remember, we need a better generation. We need our economies. We need a better society. We need better families. So we cannot get better families if we have these unborn child, if they're affected by mental health issues during their first environment in the utero. So that's why I say I want everyone in the society, I want everyone in the world to know that investment in perinatal mental health, we are investing in future, we are investing in good families, we are investing in a better world, we are investing, in better education. So I really want to emphasize, the investment of supporting, women during their pregnancy, so that we support them mentally, and we get a better generation, a better nation. So that's why I'm saying perinatal mental health is very important to us all. I thank you. So as we implement our work, I think there were a lot of some myth and misunderstanding about perinatal mental health. Some, they always say, good mothers do not feel this way. It's very common into our work. They say, parents won't struggle mentally. It's for those that are weak. Some also, they say it will go away on its own. Don't go for anything. All those the mental health issues, they can easily go, without any problem. And people, they say, this is only for mothers. Mothers are affected by mental health issues. They don't realize that, it's also both for the mother, the child, and the entire family. So these are some of the myths, that we came across as we implement. Medication, some, they say, don't take medication, it will harm the baby, as a myth again. So we tried to educate the importance of medication and therapy as well. So it's not only about medication, but also therapy. It only happens right after birth. People, they don't believe the mental health issues can affect anyone at any time. So they say it's only happens after birth. I thank you. So my final thoughts and comments around this very important topic is, thank you so much, Richard, and your team for organizing this webinar. I really want to say, as Africans, we need to come together around this very, very important topic of perinatal mental health. And mental health has been neglected for a very long time. And now we are aware. So I say, let's come together, let's invest, let's start the conversation. I think the time is now, to talk about mental health in general, and also invest more now, since we know that the science, the research, even our own experience, that during the perinatal period, the child, the mother, the whole family can also be affected by mental health issues. So we cannot leave that. Let's invest. Let's increase the conversation. I think we need to, thank this team, Richard and his colleagues, to make sure that we continue our conversation around this very important topic. So for those who want to collaborate, please feel free to reach out. I can be available for collaborations. I thank you.
What I appreciate about Linos and the work of Spans is that they saw a need and put in the work to see a new reality for moms and dads and families in his community and even broader across his country. You heard one of the final things he shared there was about collaboration. And his organization offers training that you might be interested in finding out more about in terms of counseling and therapy. And in our email tomorrow, you'll be able to get some information that you can follow up directly with Linos and his team. And that training will empower you to provide more in-depth support and care for families that you can explore further with him directly. Now, we have covered a range of information tonight. I do acknowledge we are running a little bit late, and my apologies for that. But I didn't want to rush off without acknowledging that the conversation, the chats, the videos, the presentations may have stirred various emotions inside of you. And the nature of this topic is that we are talking about real people, real stories, and real pain. And I mentioned in the introduction about how difficult it is to hold that space on a platform like this, and I can't fully acknowledge your experience. And I want to say again that if you do find yourself feeling unsettled or struggling because of this topic and conversation, I do encourage you to speak to a loved one, someone who can listen, who can stand with you, that you don't feel that you have to process this alone. And as we all grapple with this very complex issue, I want to create some space for reflection. And I encourage you to write your answer down if you're able to. You don't have to put it in the chat box. This is just for you. And there's three questions. What is one thing you are thinking differently about postnatal depression and anxiety or common perinatal mental disorders? What are you going to say differently, and what are you going to do differently? I mentioned that we are all approaching this topic with different experiences from various backgrounds, vocations, and cultures, and we will all have experienced tonight quite differently to each other. And these reflection questions aim at moving the webinar from Zoom on a device into our everyday lives, to our homes, our churches, our neighborhoods, workplaces, and so on. So this is a brief space, just 1 minute, not to think about what others need to say, do, and think differently, but just to what you need to do. So again, to reiterate those three questions, we're just going to pause slowly for 1 minute. What is one thing that you are going to think differently about common perinatal mental disorders like depression and anxiety? What are you going to say differently, and what are you going to do differently? Just 1 minute. Now, we trust that this webinar has been useful to you. We have heard from different speakers, and I recognize that you might be wondering if we're going to address another angle, and perhaps you're eager to hear additional views that perhaps have not been represented yet. And we have spread this series out over 3 sessions in order to allow time to process what you've heard, and also give us all time to put into practice the answers to the reflection questions you've just covered. The natural challenge of three sessions, is that you may have joined tonight with a question that is perhaps only being addressed in week 2 or week 3, and you've been patiently waiting for it to be answered. But we do ask you to hold on to that question and join us next week and the following to be able to engage with the whole story. Next week, we are going to be exploring the role of local churches in engaging with this topic and look at some of the challenges that churches face. We know that in the church context, the mental health might be a complex topic to talk about. And so we'll be hearing from Pastor Tony Siaka, a pastor and registered counselor, exploring how the topic of mental health is indeed challenging for the local church leader. We'll be hearing from Dr. Stel Fenter and Associate Professor Simon Hoekman, again, wonderfully, and they'll be, as mentioned, exploring the various causes of the maternal mental illnesses shared today, as well as what is some of the factors at play, both that put mom at more risk or more vulnerable, but also those things that might be more protective in nature. We will hear some stories from Flourish hosts who are sharing what they are hearing from moms in their antenatal and postnatal classes. Dr. Zamachlubi Dlamini will be sharing a biblical view and perspective on maternal mental health. She is a specialist psychiatrist and a pastor and will help to connect together a medical and theological view of this topic. And then we dive into the role of churches. Jason Sandoz is the lead for justice in the church at Common Good. He will explore what churches have in their hands that can be used to be the supportive community for moms and families in this hard space. Now, you can see that this is a full agenda for next week, and we look forward to seeing you there. A reminder is that you do need to register for next week if you have not done so already. I do know that many people attend the first event, check it out before registering for the next 2. I understand and respect that, but also don't want you to miss out next week. So if you do want to join us, it's next week, Tuesday, on the 10th of February at 7 p.m. Please click the link on the chat box to register for next week. As mentioned, we'll be posting the recording from tonight onto YouTube to be easily and freely available. You are welcome and invited to share it with anybody who you think might be interested in this topic. We will send that email with the link to the recording and any slides and resources presented tonight. And a reminder that this will be compiled together on a page on the Sikunye website that you can come back to months and years into the future. I want to thank our speakers for tonight, Dr. Nikki Dawson, Dr. Estelle Fenter, Associate Professor Simon Honigman, and Linos Muvu. Thank you so much. Your expertise has been remarkably helpful to us in exploring this topic, and thank you for sharing and contributing. And thank you too for your service to families in South Africa and Zimbabwe. This issue goes deep and wide. And I want to thank you for investing your time, energy, and resources into supporting mothers and families. We salute you for the important role you are playing. For those who are part of the Sikunye network, you are always very encouraging. Please use the chat box to thank and acknowledge the speakers for their contributions tonight. And I want to thank you as participants here tonight. I'm encouraged that there are so many people who are stepping forward to explore how they can play their part to support mothers and families. To find out more about Sikunye, please visit our website and consider following us on social media for future events and workshops. And you can find links to our website where you can find out how to subscribe to our monthly newsletters, our weekly WhatsApp broadcasts, as well as our social media channels. Just follow the link in the chat box. For some of you who it is your first time exploring the connection between the first 1,000 days and the role of the local church, I want to invite you to an introductory workshop that Sikunye runs regularly. It's called The Church and Early Life, and you are invited. We run these workshops regularly, and the next one actually happens to be this week on Thursday night at 7 p.m. until 9 p.m. And so if you want to join us, please follow the link in the chat box below that you can register and join us. You'll find out more about Sikunye and what over 2,000 churches in our nations have done to commit themselves to caring for families in this important stage of life. I want to thank all of you for being here tonight. God bless you all and look forward to seeing you next week in session 2. Good night.